Hey guys, welcome back to my channel, CMoneyRN here. Just a quick background if you haven't subscribed to my channel yet. My name is Christian, I'm an ICU nurse here in Las Vegas, and I just graduated NP school back in December. So I'm back making videos. It's been a long time. I just released 2 videos recently, and I plan to release more content for you guys right now. So let's get to it. Anywho, so I just want to bring this video and talk about a sensitive subject, something that is not often talked about in the ICU, but is an integral part of working in the ICU. Now, I've been working in the ICU for over a year and a half now, and one of the biggest things that I have to deal with on a day-to-day basis is end of life, discussing end of life. And in the ICU, when COVID was first bad during the first wave, into the second wave, and now we're entering into a third wave, we've encountered so many patients who get onto ventilators and end up not coming off of it. Conditions have changed from day to day to week, and it's so unpredictable. And the question that I want to bring up to you guys is, when is it appropriate to start talking about end of life? Is it a week after your loved one is intubated? Is it 2 weeks, a month, or even more than a month? My opinion to that, and this might differ from other people, is as soon as possible. I feel like as soon as you have that conversation about end of life, establishing a power of attorney, establishing a decision maker, the better, because the more you push and push and push, the worse that this patient gets, your loved one gets, while they're here in the ICU. And I've encountered this many times. I've seen patients who have been stuck in the ICU for months or even up to a year. Could be related to insurance issues, could be related to the family who is on the fence about what to do regarding end of life, or it just could be a standstill. So when we're dealing with this type of sensitive question, I feel like it's important to have that discussion early on, especially during the early stages. And over at the ICU I work at, typically when a patient is intubated, we give them about 2 weeks. Every day we try to wean them off the ventilator, meaning we take them off of the sedation, we test how they are able to breathe, we switch the vent settings from something called vent control assist control to a CPAP mode where the patient does most of the breathing on their own as opposed to the vent doing most of the work, and we just see if they're able to come off the vent. During that weaning process, like I said, the sedation is completely off at the time. The patient is challenged to do more of the breathing on their own. And one of the big parts too is also asking the patient, simple stuff. Are they able to follow simple commands such as, can you squeeze my fingers? Can you blink your eyes? Can you wiggle your toes? We need to be able to see that you're able to follow those commands, because once we take you off the ventilator, you need to be able to breathe on your own. Take deep breaths. If we instruct you to take a deep breath, we need you to be able to do that. We need you to be able to clear your secretions. And if we notice that if you're struggling with doing that as we're trying to wean you off the ventilator, then unfortunately you are going to remain on the ventilator. This is a conversation that I have, unfortunately, with families every single day. Well, when COVID was really bad, even up till now, COVID is still getting bad, but it's getting a little bit better. I've gotten many calls, when is my family member going to come off the ventilator? And I say the same thing over and over again. Every day we're trying to wean them off the ventilator as much as we can. And sometimes it's good news where I tell them, you're doing better, we're going to extubate today. But a lot of the times, they're not doing better, and we still have to try again tomorrow until the next day. Well, once 2 weeks passed, depending on your hospital's protocol, for me, at least at my hospital, after 2 weeks, that's when you want to have a discussion about trach and PEG. So tracheostomy, as you know, is an alternative long-term access for intubation and also for ventilator care. So you create a little hole into the neck, and then you create an airway access that connects to a ventilator. And then you also have something called a PEG tube, which is a special tube that goes, towards the lower abdomen on the side, and that's where you can give proper nutrition. So the reason why I want to bring up discussing end of life early on is because, when it's been past 2 weeks, 3 weeks, or a month or so, you need to be realistic with the family members, their significant others, as much as possible. Do you feel like they're able to reverse out of this? Are they going to get better? And if the answer is they're not going to get better just based on the labs that you've been getting every day. They're not responsive to your vasopressors. They're not responsive to the weaning trials. Then you have to be very clear to them, you know. Say that every day we've been trying to wean them off the ventilator, but they haven't been successful. You describe their condition, the state they're on. Talk about quality of life. I feel like this is the discussion that I've had with one particular doctor while working in the ICUs. You know, why wait, you know, when to the last minute, when the patient is at their end, when they're on the brink of death, to have that conversation about end of life when you could have done it from an early on. If you can establish with family members and significant others, friends, anybody who's close to that patient that you're taking care of, you want to be very clear that, you know, you look into the quality of life. Sure, maybe might be some brain activity. They might not be brain dead. They could just be brain injured. But you look at the quality of life. When they come off the ventilator, are they going to be the same person they were years ago? Are they going to be up and walking down the hall, you know, in public? Are they able to resume their activities of daily living? Can they feed themselves? Can they clean themselves? Questions like this and also points like this have to be addressed very clearly from the beginning, so then it helps family members make a firm and good decision. And when you wait to the last minute, when you allow the patients to suffer, when you allow them to be on the brink of death when it's too late, it's very difficult, because now the family members are just having a hard time accepting that reality. And so the sooner you have that conversation with the family members, the friends, and everyone, the better, so you could slowly transition to them. And different alternatives that you can take in terms of what you can do for long term, especially if you're on a ventilator for a long time. If you want to continue to have the patient on the ventilator for long term, you have to be open to tracheostomy and peg tube. And also you have to be open to the fact that you will not be able to stay in the hospital for a long time. A lot of times, you know, because it costs the hospital a lot of money, it incurs a big charge, we try to transition patients outside of the hospital setting to a long-term care facility. So if you want to go that route for your loved ones and family members, if you want to do that and keep your loved one on a ventilator, that's an option for you. Another option too that we like to have in the hospital too as well is called comfort measures and hospice care. Comfort measures is when we take someone off the ventilator, we extubate them, that's the correct terminology. We see how they do. We give them medications, typically Ativan, morphine pushes, and allow them to pass naturally. It could take seconds, minutes, days, hours, etc. Usually it takes some time, but eventually we try to transition to hospice, and that's considered hospice care, where if they were stable for a couple hours, a hospice facility in your local area will be able to accept the patient, of course based on the insurance that you have. So that's something that you also want to consider. So I want you guys to kind of just take this video, you know, if it helps as a resource, I'm glad it does. And I kind of just want this to put this into perspective. I wish this was something that I knew going into the ICU, that this was a conversation that I was going to have. And you know that typically it is between doctors and family members, but as the nurse, you are also a big part of this conversation. The nurses, not just the nurses, the respiratory therapists, the case managers, social workers, the pharmacists, I'm sorry if I leave anyone out, physical therapists, occupational therapists, different specialties are all involved in this process. And so we make these recommendations because we try to see what is best for the patient. And if we feel like that this patient is better off coming off a ventilator, we are going to be very clear for it. And as a nurse, I myself, my duty is to be that advocate, to be able to help you come to that decision, explain things that the doctor tried to explain to you, put it into clearer terms, or even setting you up with the resources, setting you up with someone from hospice, someone from LTAC, a caseworker, that someone you can talk to about all of your options. So if you guys need help, don't hesitate to talk to your nurses, to talk to different parts of the hospital, your staff, because those are going to be the best resources that you possibly have. And I hope this video helps. This is something I wish I knew going into the ICU, but after working over 1.5 years now, I'm glad I know it. I've had this conversation multiple times, and it just hits harder every single time. So, like I said again, hope this video helps, and I'll see you guys until next time. Take care. Yeah.